listening to the Medic Materials Podcast, hosted by Mike Turek, Emily Yates, Kelsey Coons, and Gerard Cuomo. All are current EMS providers and educators with a combined 30 years experience. Each month, we discuss EMS news, medical science, and review actual EMS calls, bringing many educational opportunities to the listener. Portions of the calls have been altered to protect the privacy and identity of all involved.
Hello and welcome everyone back to the Medic Materials Podcast. Gerard, M, how are you guys?
Doing good.
Doing good.
What beef variety are you chomping down on right now, Gerard?
Buffalo.
Buffalo.
Buffalo, yep.
I can't honestly say I've ever had buffalo. Is it yummy?
It's fantastic.
It's fantastic?
Mm-hmm. Yep.
You know,
as somebody who has had caribou, bison, buffalo, bear, what else have we...
Moose.
Did we shoot? Moose, yeah. My aunt makes this moose stew that's like fucking... It's like the greatest beef stew you ever had. Only think of the meat being even more fork tender. Yeah.
Delicious.
Yeah.
Delicious. I'm still salivating.
It pays me have relatives that live in Alaska.
that it does. That it does. So we are getting back on track here in the month of January, which is awesome. It was good that we skipped December and just said, fuck it, we don't need it.
Fuck everybody, right?
The Patreons are gonna get their episode, but everyone else,
right?
You just
go
lose.
fuck yourself,
right? What did you do on the other? But we're
as I try not to cut my fingertip off here.
I know, right? We are still missing. We are still missing Kelsey. However, you know what? I felt like it was a good time to reintroduce one of the favorite people of the show.
Oh yeah. Why?
Because you're Kelly, 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 Kelly of mine.
After her long-winded absence, Kelly returns. So she will have some very good insight on today's episode, which I'm excited for. And Gerard, you, I know, have been waiting for this day for so long, and we are going to purposely hype this up so that all the pressure falls on M's shoulders.
Absolutely.
Because for the first time ever, well, actually the second time ever, the first time ever on an actual episode.
Yeah, because it was so bad we deleted it.
No.
True.
No, it was so good that the audio sucks so much and I couldn't use it. I still have it. I actually listened to some sound bites of it.
Didn't we end up putting it up anyway?
I don't know. No, I don't believe so.
No, we didn't.
No.
We should have.
Yeah, because like right now I'm going back and listening to old episodes, which I must say are fucking cringeworthy.
Really?
Oh, dude, there's like... Before we had a flow and a format and the girls joined and oh yeah, it's been bad. Like I'm up to episode 5 now and I'm just like, how do people listen to 1 through 4?
Wow.
They're just all over the place. Like we're still learning how to do this whole thing. So thank God that we get better with practice. Cause I feel like I told you this the other day, Gerard, I barely edit these whatsoever. Like we've gotten it down to such a format that the Patreon ones, I literally record it, I put it into my video editor, I add 2 things, I hit render. Literally nothing else goes into it. They're up in 10 minutes after I'm done, like after we stop recording. The free ones, I listen to the whole thing again just to make sure that there's nothing like grossly negligent that we say or, you know, really, really, really dirty that we say. And that one wasn't good, Gerard. What'd you just try?
What was that?
Swallow it. Swallow it. You make it
salmon jerky.
Salmon jerky. Yo, that's yeah.
No bueno.
You're making the face of like you're trying to suck down. Oh,
Oh, it just got the back end.
I was gonna make a really dirty joke, but I'm gonna let you suffer.
No, I just
in your
caught the
pain.
back end. I didn't take it in the back end.
No, that's not what I was gonna say at all.
Oh,
I wasn't
that's
even
what I
gonna.
would've said.
I wasn't even gonna make a back end joke. I was gonna make like the the first time you try to swallow joke, and
There we go.
but
Yeah,
that's
I remember it fondly. I made $1.98 that day.
No.
oh, that's the wrong one. Damn it. There we go. So we are getting ever so close to the major announcement on or around February 1st. Depending on how the next couple days go, I'm going to be making a major announcement on Patreon. And then hopefully Kelsey will be here for the February 1st episode, where then I will allow her to make the ginormous announcement in her rig check. And then we'll announce it to everybody on all the socials after that. But yeah, I think what's coming, we've all been working on for a long time, and we finally have the opportunity to run with it. We've paired up with a very awesome company, and I think what comes next for the whole Medic Materials chapter, as well as the whole podcast, is going to be so cool and so exciting. So make sure that you're listening on February 1st for the major announcement.
But it's not Stone Cold Steve Austin's Broken Skull IPA.
Well, that's a disappointment.
No, it's
I
not.
I know.
I've emailed them like 4 times and I never get a response. So I'm pretty
I know.
sure
I mailed once. I was like,
I'm sure they're like,
it's worth a shot in the dark.
Yes, exactly. Go pound
You never
sand.
know.
But
I guess he just doesn't give a fuck about first responders.
I guess so.
You know?
I guess so.
He
Which
just
is really
doesn't care.
He just doesn't care.
Let's start the hashtag campaign. Stone Cold doesn't care. Hashtag.
Yeah, and that'll be like, and then he'll just put up memes of middle fingers, and we'll be like, oh, it's Stone Cold. Yeah.
Hey, we tried Condite, and now we can try shaming. Right.
Why not? Whatever works.
Right, fuck it.
Whatever works.
We're going to lose.
So, Emily, the floor is now yours.
Oh, she
no
needs
pressure.
intro music.
I don't have.
Nope,
Oh,
nope.
hold on. Wait.
Not Butch's.
We've got a badass over here.
Oh, there we go.
There you go. That's all I got for Emily.
All right.
All right, so I'm going to try and follow the same format as you, Turek, but I'm sure you guys will keep me on track. So we are in an urban setting. This is a busy commercial agency. They are staffed with a paramedic and an EMT. It is ungodly early in the morning, and they're dispatched priority 4, alpha priority, for a 54-year-old male with increased lethargy. Their response time is about 10 minutes from where they are to this call.
Is it
So about 10 minutes.
is it a house or like where did they get dispatched to?
So it is a duplex, I guess.
Okay, so a house. Okay. I just want
Yes,
to
a
make
house
sure
with 2 residents in it that aren't
Not a
related.
nursing home.
not
Yeah.
No,
not
it's
a
not a
nursing
nursing
Okay,
home.
that's the main thing. Like I don't care where
Yes.
they were, just not a nursing home. Okay.
No,
'Cause-
they're going to
'cause
a
that
duplex.
takes- that-
There is a downstairs neighbor, and the patient is upstairs.
Okay, because that like takes a whole lot of things off the floor right away when you're thinking not a nursing home lethargy.
Right. Like, this might actually be legit.
Right.
One would think. Wait for it.
Okay.
So this patient is complaining when you get on scene. He is sitting up on the bed. He is pale, warm,
Ooh.
dry. He's complaining of generalized weakness, body swelling, and the inability to ambulate, which has been going on for the last 2 days, but he's generally felt unwell for 2 weeks.
Okay.
Hmm.
So
On scene, you
What-
have his wife, who says she has been out of town for the last month, but has called this man, her husband, every single day, and thought that over the last 2 weeks, she thought that he just sounded unwell, I should say.
Okay.
sounding different. Okay.
Sounding unwell, no like change in his speech, nothing like that. Just sounded like he didn't feel great.
Okay.
What do you think?
My first question is, how much Viagra has he been taking for the body swelling?
What?
I got it.
Gerard got it.
I wish I didn't, but I got it.
Okay. Don't know. Didn't ask.
Still,
It was not on my level of disgusting humor. We'll put it that way. It was definitely like kindergarten stuff.
Yeah.
Yeah.
Come on.
You gotta start somewhere.
You make poop jokes. I don't want to hear about the level
But
of dirty humor.
I make poop jokes that are fucking gold.
They're still poop jokes.
There is a varying degree of poop.
Anywho, beyond the dick jokes.
Right.
Before I make another poop joke.
Here we go. So your patient's sitting up on the edge of the bed. He's consciously oriented ×4. He's speaking in full sentences, although appears somnolent and lethargic.
Okay.
Skin is pale and warm. Good motor function ×4. When you look at him, you see pitting edema in all 4 extremities.
Okay.
Worse in his torso and upper extremities than his lower. He has a very distended abdomen to the point that his belly button is pretty much flat.
Wow.
Is he on dialysis?
That was literally heart failure or dialysis was where I was
thinking
going
about
with this.
CHF. Yeah.
So he's not a current dialysis patient.
Okay. History of CHF.
Should he be a dialysis patient?
He has history of a cardiac arrhythmia that he couldn't explain, diabetes type 2, and hypertension.
Diabetes. Okay.
Diabetes.
So instead of jumping the gun, just do ABCs, primary assessment, get that out of the way.
So besides the fact that he's pale, he actually looks pretty good. He's talking to you.
That's
He says
good.
he's only short of breath when he's laying down, but sitting up talking, he's speaking in full sentences. No obvious shortness of breath. No.
Full of fluid, that's what I would suspect would be normal.
Yeah, some orthopnea.
Yeah. Okay.
For sure. No chest pain, no belly pain, no nausea, vomiting, nothing like that.
Okay.
Did we do lung sounds in the primary or no?
They did not.
Of course.
Oh.
Ooh.
Damn.
They did not. But they do mention that he has a rash in his groin. And when they further investigate that, they find that he has not been able to ambulate the last 2 days to go to the bathroom.
He's just been peeing himself and shitting himself.
Potentially.
This is turning into a poop joke.
Yep.
All right. So he's soiled himself, and he hasn't been able to get to the bathroom. I'm just. I know it's going to sound weird, but the odor of the urine, very pungent, sweet.
Not UTI.
Okay, we're just going to rule that out right now.
We're just going to go, not a UTI today, Gerard. I would do that to you, but I didn't today.
Thank you. Appreciate it. I was like, if this is her, she's going to give me a fucking UTI. I know it.
Right?
Right.
So
All
they
right.
decide at this point to try and get vitals, put him on a 4 lead, and eventually put him on a 12 lead at this point. Okay. So they get a heart rate in the 90s. I think she told me like 94 at the time. I don't remember the exact, but it was in the 90s.
Okay.
They put him on a 4 lead. They don't like what it looks like, and they put him immediately on a 12 lead, which I have sent to you guys, which you guys need to describe to me.
Okay.
It's a bunch of squiggly lines.
Well, from what I'm seeing is
Hey, hold on.
Hold on a second. Hold on.
I want to call Emily out. Didn't you work in the like cardiology tech unit reading EKGs?
So ironically, when I read this, I did not think anything that you two did. So I want you to read this because you thought exactly the line of this paramedic.
So when you were holding it up on the screen, it was really hard to see.
I agree.
When I'm looking at on my phone where I can actually zoom in and look here,
I agree.
I think it looks different than what I was originally stating. And I'm pulling it up again here. I just got to.
So let me read the black box that it put out with. It says it meets ST elevation MI criteria, anterior septal infarct, possibly acute. inferior lateral ST changes with some injury / ischemia and generalized low QRS vultures. That's the message that this put out.
Yeah. Which, whatever. Like.
Right. But I'm just, they
Right.
can't see it. That's what it's saying.
Right.
Well, I mean, going from just looking at the leads, I mean, my first thing, like we talked before, I was like, well, it looks like there's something septal going on with some anterior stuff, and then you look up at the top, and that's exactly what the doc in the box is saying. But I mean, that's just looking at it right off the rip. I honestly, it's junky. I wish you could put it up so everybody could see, but
I mean, I can link a picture of this. So the one thing that I'm noticing in this, right, and Gerard, see if you follow here. There is widespread depressions everywhere, right? That's the one thing that I'm seeing. Like,
and that's what
your lead to, your V1, V2, V3, and V5 and V6 are all depressed. Okay.
And that's where I was kind of going. Like, I didn't really see anything that made me jump and go, oh my God, that's a STEMI. But I was like, man, that's some wide shit with some freaking major depressions here.
Well, I'm curious if, now this is not my strong suit. I will be the first to admit that one of the hardest things for me is bundle branches and EKGs. But if you look really closely on some of these, there's that rabbit indentation on some of these QRS waves. Gerard, you're holding your hand patiently like a fourth grader.
So, yes, I just received a text.
Do I need to hit his music?
We may be having the
Do
Charlemagne of cardiology here. The Mahabuchi himself has stated his desire to join us.
Oh, in mid-episode.
Oh
man, this is going to be interesting.
So before we even say one thing about this, let's see what he has
to say.
Text
in the EKG so you can see it.
He better.
I'm sending it right now.
He better join the Discord.
Oh, that's what he's doing right now. He's downloading it now.
So the surprise guest.
If you can find the right button.
So Butch is here.
Mm-hmm.
So Gerard,
howdy.
You decided to send the EKG to Butch.
I did.
And then the Mahabuchi was like, I need in on this.
Right. Yep. It's like putting the back signal up, you know?
Right.
You just put an EKG in the sky.
which honestly, I can honestly admit I've done that before where I'm on a call and I'm like, I don't know what this says. I'm going to text it to Butch and see what he says about it. So yeah, I've totally pulled that card before. It's not
the first time.
Yeah, it's a good card to pull. Yeah, so we were just going over what we were kind of thinking this was, and you had an opinion, Butch. So we're gonna go right to you and hear what your opinion on this EKG might be.
So yeah, I definitely see the definitely see the depressions going on and the lateral leads going on there. And for once, I don't see my depression in AVL. I'm like, oh my God, no, there's no depression in AVL. So I mean, it does meet some ischemic criteria going on there. So I would definitely treat this, if the patient is symptomatic, I would definitely treat it as a cardiac event going on. I mean, like I said, I never treat what Doc of the Box says, but yeah, there's definitely some cardiac event going on with this patient. So
Right. So, just kind of run through really quick.
I was going to say, let me recap real quick.
Yeah.
So you're on the scene of a 56-year-old male complaining. The initial call was for generalized fatigue. You show up on scene. He's sitting on the edge of the bed. He's conscious, alert, and oriented ×4, speaking to you in full sentences, totally alert and oriented, complaining of generalized weakness, body swelling, and inability to ambulate for the last 2 days, but has been generally feeling unwell for 2 weeks.
okay.
And vital signs were what? I don't.
So
'cause I
they're
know they were
a
getting.
We didn't get to that yet,
vitals.
but pitting
Well,
edema
so
in
they're-
all extremities too.
Right.
Yes, pitting edema in all extremities. His belly's distended to the point that his belly button is flat. But so they put him on the monitor, run a set of vitals as they're doing a 12 lead. They're doing all of this, but they get the 12 lead first. They show this.
Okay.
What I see in this, I'm with Butch. I see some ischemic changes. I see a wide QRS, and I see a very short PR.
Yeah.
But I see a lot of like flip T's,
Yeah.
depressions. Like I see some ischemic changes. So they finally go back to the blood pack. They're unable to get a blood pressure. Heart rate is in the 90s. On the EKG, it's 96, I believe. When they finally like document the vitals, it's like 94 or something. So right around there. SpO2 is 94% on room air.
Did they? Was the blood pressure manual or NIBP?
NIBP.
Of course.
Ugh.
So they can't get a blood pressure. They immediately try a manual.
Okay.
They are unable to get a manual.
Really?
That's
What
I'm
are our
told.
lung sounds sounding like?
We've already tried
Say
to
that
get
one more
lung.
time.
He
Lung
wants
sounds.
lung sounds like I did.
Oh, we lost Emily.
Oh no. That was weird.
Yep.
Not even my fault this time.
Nope. Not. And
It's all your fault.
She's still in the call, but yet she's gone. Hello.
Shit, hey, potted out of here.
Hey, there she is.
Oh, there's a little Discord guy.
That was
That was-
peculiar.
That was weird.
I don't see you.
Yeah.
Weird.
Weird.
Weird. It's weird.
There we go.
Oh,
Okay.
there we go.
That
It
was
just
really
kicked me off.
bizarre.
Yeah,
it
you were
just
like in
kicked me off of
mid-sentence.
Discord.
Yeah.
Yeah.
It kicked me
Oh.
off.
Jerks.
I
So
know.
so yeah, he was asking about lung sounds like I did earlier, but they have not taken them yet, Butch.
So they have
Ugh.
not.
So we got edema going on to the point of, flat abdomen. We got guy weak for 2 weeks. We've got, barely get a pressure. We got cardiac changes, and we haven't got lung sounds yet.
Correct.
That's where we're
Okay,
at.
I'm out. I'm out.
I'm out.
Fly car back in service. See you later, bye.
I mean,
So these providers,
no, go ahead.
these providers look at this EKG and say, "Oh, we have a STEMI." So they put him on low flow O2 at 2 liters via nasal cannula, or maybe it was 4. I'm sorry, I may have fucked that up. And they transmit the 12 lead to the hospital they're going to. So the paramedic gets on the phone with the doctor, the other providers, and they have first response fire on scene at this point. Put the patient in a stair chair to get out to the ambulance.
At least they didn't make him walk.
He couldn't, don't worry. So they call a doc. They get on the phone. They say, "Hey, we're coming in with a STEMI. Get the cath lab ready." The doc says, "I don't think it's a STEMI, but come on in. We're ready for you." Doesn't give vitals because they don't have any. Well, they don't have all of them. Says, "Keep doing what you're doing. Come on in. Let me know what the blood pressure is when you get it." They get him in the ambulance. They recheck his heart rate in the ambulance. His heart rate is now 40.
Oof.
And he is junctional.
I can see where this is going.
If you Google a junctional rhythm, that's it.
Okay.
So they put him on the pads and they transmit. They finally get a blood pressure of 50 on 30.
Okay. Which is, so they put him on the pads, but they're not pacing him at this rate. Like they're not
Nope.
pacing at this point, right?
They're not pacing. They put him on the pads
Just as
for
a
imminent
precautionary.
decline, as they describe.
Imminent. Okay. All right. So
I'm good with it.
yeah, I'm not. Yeah, I'm okay with it.
I'm fine with it.
Yeah, I think it's a smart choice. Be ready. Don't be behind the 8 ball. So heart rate's in the what? You said the 40s?
Yes.
Okay.
Blood
And-
pressure is 50 on 30. His SpO2 is 99% on his low flow oxygen.
No, they got this just getting into the ambulance, right?
Yeah, so he's just gotten to the ambulance. They're still
Okay.
on scene, haven't started moving yet.
Okay, so we're going to start getting a line and all that. We haven't done any of that stuff. Okay.
They made 3 attempts for an IV, were not successful.
Time to drill.
Yep.
So this
Well,
patient remains conscious, alert, and oriented. Not complaining of anything besides generalized feeling tired and swollen, as he describes himself.
So, I want to pause for a second because I'm re-looking at the EKG on my phone on the 112. Did they ever do repeat 12 leads? Like, do we have anything but the first to look at any changes or anything, or did they just go?
They did one further down the road.
Okay, so there in 1, 2, and 3, there's a lot of garbage.
Yeah, it's a lot of artifact going on.
It's a
there.
lot of artifact, a lot of garbage.
Mm-hmm.
If you look at the V leads, they look a lot better.
Yeah.
They're a lot clearer. But I'm really only seeing, unless it's buried in the T wave, which it very much could be, there's not much delineation for a P wave in the V leads on this 12 lead. Like
I see it, but
like
I don't know how to show you.
Like you can see
like
you can see like a slight bump here and there, but it's not on every complex. You know?
Yeah, you can see it kind of pronounced
I
in
think it
V3.
is.
You can see it in V3, you can see it in V2.
Right, and that's about it. Like you can see a clear bump in those two and a slight one in V5. Or I'm sorry, V4.
So I can see it in 1, 2, 3, 4, and 6.
In the V leads?
Yeah, in the V1, V2, V3, V4, and V6. I don't really like.
You can see it in V1. You can definitely see it in V2.
Yeah, see,
there is in V3.
Are you guys like right before the Q wave? Are you saying that's the P wave?
Yeah.
Okay. All right.
The problem is there's a lot of artifacts in there. Hiding.
The smallest unit of measure on a construction site, rise.
No, I know what you're looking at. I just don't know if, and this is why I hate cardiology, because everyone's interpretations are different. I don't know if I would call that a P wave.
Here's the problem. Did they take this EKG while this guy was still sitting on the bed with all this edema? You know what I mean?
The one that you're looking at, they did.
Yeah.
Because you're not getting a clean reading with all this swelling with him sitting up, I'm assuming he was probably tripoding because he was feeling like crap. You know what I mean?
He's not, because he's not having any shortness of breath. He's sitting up, having a conversation.
Interesting. All right, that was the only thing that I was looking at while we were having this discussion. I'm interested to see where this goes.
What
are you thinking so far?
So the more I'm looking at this, the less I'm seeing anything that would make me call and say, "Hey, we're bringing a STEMI in."
I agree with that.
I agree.
So what made them jump and do that?
Doc in a box.
The doc in the box.
Oh, okay, gotcha. Okay.
I can understand why the life pack would yell STEMI on this because of the depression, but I don't understand why it yelled. There's no elevations anywhere, but I can understand why the life pack would say STEMI. But
and even still, the QRS is fairly wide in the V leads. Like you're looking at, I mean, almost 3-4 boxes.
Yeah.
So you're looking at just on the border to, 0.16 seconds, so,
yep.
I mean, you have a wide QRS. I'm terrible at them. Could this be some form of bundle branch block? Could it be medication related? Did we get like a good history? Is it electrolytes? There's a lot of things that can cause widened QRS waves with lethargy.
So it's funny you should ask, because at this point they ask more about his history. So he has history of type 2 diabetes, which has been well managed on his home insulin regimen.
Is he on
They get it.
Seroquel?
Is he? No, he's not on Seroquel. History of hypertension, which he has been taking his medications, and he has a cardiac arrhythmia, which is not treated, but he doesn't really know what that's about.
Let me guess, he's on a beta blocker. Oh.
No, he's not on a beta blocker, and he's not
No?
on a calcium channel blocker.
Interesting.
So they decide to check a blood sugar, and they get 90.
Okay.
Okay.
I had to throw that in there. I am Miss Queen Blood Sugar.
I know.
Well, at least they did. I mean,
Thank you.
it's a plus.
I mean, it is a guy with lethargy. I would have probably checked one as well.
What are you guys thinking? Like, what are we going to do for this man right now?
So I'm going to go with Gerard's initial thought of he's already on oxygen. He's already on the pads, not paced yet, but you know, we need an IV.
We need access.
We need access. We need fluids to start, right? Because blood pressure, and if this thing goes far south, any farther south, we need access. So, I don't know the skill level of the paramedic EMT. You know, you said they tried 3 times. If that's the case, drill.
True.
Like there's, unless there's some, some sort of, vein that they have not tried yet, like, they do like an EJ or something like that on a conscious patient, you have to drill at this point. Like clearly your patient is not okay. Like they're hypotensive, they're bradycardic, they're, not really lethargic, but, they're not feeling well. They're not perfusing well. They're pale, right? What are peripheral pulses like? Do they even have them at this point? We don't know. This is an unstable patient.
Yeah.
Clear as day. Unstable patient.
So they have him in the ambulance. It is about a 10 to 15 minute ride to the hospital that they're going to, the one that they called the doctor at, which is a cardiac center. So kudos to them on that. They switch the O2 to high flow. That's where their 3 attempts at an IV come in. They cannot get them, so they defer the IO because he's conscious, alert, and oriented and not complaining of anything, and do another 12 lead.
So he's alert
This
and
12
oriented.
lead has a heart rate of 32 and is coming out as a junctional rhythm.
Yeah, he's not gonna be conscious and alert very much longer, dude.
Right.
Yeah, the only thing he's putting right now is imminent death.
Yeah. Yeah. At this point,
Might as well just go put the Lucas on him now. Fuck it. You're not gonna do anything. Just give it a minute.
I mean,
oh, what is this you're putting on me? Yeah,
yeah.
It's fine.
Realistically, though, you're not wrong, Gerard. Like, if you're not going to treat this, right? Because the only way to treat this at this point, right? Say they did everything, right? They get an IV, they get fluid, right? That's not going to increase rate. So
it's definitely a pump problem.
Right. The only thing that is going to fix this is either meds or electricity. So
and I think before giving fluids with this particular guy, I would maybe just IM him quick little bit of fentanyl, or if we get the IO, go ahead and throw a little fentanyl in him real quick and just start the pacing.
Yeah.
See if the pacing will fix our blood pressure problem.
Right.
It might not.
It might not, right?
Mm.
Piggyback the saline off of that. I'm okay with that.
Right.
Yeah, we're past the point of atropine helping anything right now. We need to get some electricity on this guy's heart.
Yep.
Yeah.
I 100% agree.
Yeah. If the output goes up and we get, an increase in BP, which, hey, win for us, great. If not, throw a little bit of fluid in there. Maybe if the longer duration transport, use a pressor.
Right.
That's it.
Yeah, I'm in the same boat. I think with what you're looking at now, a junctional rhythm in the low 30s with this guy not perfusing, you have to go to the ACLS of this guy is unstable. Let's fix him with immediate electricity. I think pacing's your only way to go.
You put the pads on. Something made you think of doing that.
Right.
Unless you're thinking you're going to do cardiac arrest, which you probably will if you just keep sitting there looking at them.
Right.
Yep.
I think that's what they were thinking. So at this point, they call the doc back and we're like, hey, this is what we have. His heart rate's now 32. Transmit that. Doc looks at it and says, okay, have you tried atropine? They say no, because we don't have any access.
You mean he didn't ask for the blood sugar?
Miraculously.
Right.
They don't have any access, so they can't try the atropine. The doc tells them if they can get sedation on board, that they can pace. If they cannot get sedation, they cannot pace. It's ultimately that conversation.
Since when?
Hold on. Let me reach my button here. Okay.
Oh, I can pace without sedation. Yeah, just hit that little button right there.
So I'm sorry.
This is the conversation with the doc.
Okay, hold on. Let's just pause here for a second. So now you have an EMS crew. Let's just recap what I envision in my head here. We have an EMS crew that is clearly uncomfortable in the situation that is in front of them, right? And they have deemed to do nothing over something because of their level of uncomfortableness. Secondly, because they're uncomfortable, they're leaning on a doctor to give them answers. Okay, I'm okay with people doing that. Mm-hmm. However, the doc has now realized that this person, this paramedic, this EMS crew, is incompetent of making good choices. So now the doctor has lost all confidence in them, and that just telling them, don't do anything, just get here and we'll fix it. Mm-hmm. That is the worst spot to be in as a patient, because you are literally just rolling the dice on whether or not you're going to make it there. Right? Yeah. So, and you have protocols. Like, we have protocols for pacing. You do
but
not.
Shame
you don't
on this
need
provider for not advocating for the patient.
Right.
That needed to be a conversation, not just like, yeah, okay, doc.
Right.
What?
Right.
And I'm sorry, like, you didn't even need to make that phone call.
No, you didn't.
Nope,
no.
You
right?
didn't.
You didn't. You had protocols. You don't even need to sedate to pace. You don't need to do pain management and pace. So the fact that, now they're going to, not provide care that is warranted at that time because they're waiting on a doc's order for sedation and or pain management when their rate is going to kill them before the pain does. That doesn't make any sense to me.
Mm-hmm.
Like, I think that's just a nice way of the doc finding the loophole instead of being like, you're stupid, get them here.
Right.
Yep.
That's a scary spot to be in. Just my thoughts. I don't know.
Yep. I agree.
100%. Yeah.
That's not a good assessment. Yep.
Yeah. So does this guy die? Please tell me they don't.
Well, no, let her finish.
Well, so they don't do anything. They're
I know,
right to the hospital.
jumping.
That's the end of this. Like they.
the end scene.
Well, it's not because I do have an update, unlike our other episodes. However, for the EMS,
right.
For the EMS trip, like that's what they did. That's it.
Wow.
Deliver the patient, bundled up and all.
And the sad thing is like, we always. Oh man, fucking bullshit call, another fucking bullshit call, another fucking bullshit call. Here you got a chance that it is not a bullshit call. Here's a chance you get to fucking do shit. You get to actually fucking take some of that shit you learn, some of those fucking expensive toys you got,
and apply it. And
some of them fucking fancy drugs, and do all kinds of fun shit with it, and see how fast you can get it done.
Right.
Like fucking, hey, time me, Here's your chance to play. And you're like, yeah, I'd rather sit over here on the bench. I'll get my wedgie later.
Especially when you talk about where this, because this is a very busy commercial agency that is in an urban environment. So a 15-minute transport is probably on their longer side.
Probably,
so this is where you really get to like play and see your outcomes.
Do something.
Right.
Yeah.
Right.
I mean, you can actually do some of the stuff you've always bitch and complain you don't get to do.
Right.
Right.
You know,
Right.
so and it's one of these things like if there should be like a tag or something made up, especially at those types of agencies where, you know, if someone gets a call like this and they do that, they should get a tag that they have to wear around their fucking neck that says, I am not allowed to bitch about the next shuck. Because you had your chance and you fucking blew it.
Right.
Mm.
And, you know, coming from someone that worked commercial in a busy system in a city and then going to rural and, you know, becoming a paramedic in the rural section and not in the city section, we bring up my father-in-law quite often, but he used to sit there and go, yeah, I expect you when you're a paramedic to do this, 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 and this in the time that it takes us to go from here to here. And it was like 7 minutes. And I'm like, there's no possible way to do all of that. He's like, yes, there is. And then we would go do a call and he'd, you know, O2 oxygen monitor, dual IVs with dual fluid hanging. And, you know, he's still able to do other stuff in 7 minutes. And I'm like, how's that humanly possible? So you can, if you want, you can get a lot of things done. You know, the on-scene times for my wife when she's flying is 10 minutes. They need to be, you know, off the scene in 10 minutes, which means a lot of times they are doing an assessment. They're doing, you know, all of the cardiac monitor stuff. They're doing first push meds as well as possible RSI packaging and getting in the aircraft in 10 minutes. And they do it often. You're telling me that it's not possible? Like, that's a lazy excuse to be lazy. You know?
Or not confident in what you're doing.
Right. And the fact that, you know, you can clearly tell they're not confident from the beginning because they're using doc in the box. You know, like
True. Yeah, I was just thinking about that. Yeah.
You know,
like, you know, in their head, they it's a STEMI, and no matter what doc says, piece of paper still says STEMI. They're like, oh, fucking STEMI. So, and that's all they're going with in their fucking head. So they're already out of their comfort zone.
Right. So let's go down that road though, because they said it was a STEMI, right?
Didn't treat it.
And then they didn't treat it. There was no aspirin. There was no nitro.
Nope.
I mean, nitro was out of the rip, but there was
I'm good without the nitro.
I remembered the blood pressure was like 50 over nothing. But
yeah, he's going to get there all by himself. Don't worry about it.
There you go. But there was no aspirin. There was nothing for cardiac treatment.
Yeah.
So again, what were you treating even if it was a STEMI? Which clearly, you know, it isn't.
Don't know.
I don't know. So anything for you to Butch to add onto this one?
No, I mean, yeah, they just
they're
not confident in their skills. Yeah, they're just. I have issues with all the time when I hear medics who should know better. You know, what I would call a doc in this. Why are you calling a doc in this? Like you said, we have protocols to follow. We have, you know, down a list, you do your protocols. And then when you run out of things to do, then you call a doc. Like, doc, I tried all this stuff. Now what do you want me to try to do? I mean, like you said, I mean, they're just clearly not confident. They can't read an EKG. I mean, yes, people have problems sometimes with EKGs. You get a funky EKG and you go, you defer to your next, you know, person on the list, whether it's me or a doc, you know, whatever. But, you know,
it's me or a doc. You know, the doc would be good for you.
Definitely good for you. But yeah, it's just, I mean, you gotta. I understand sometimes you get medics that are fresh out the box and you get scared, but you gotta have some confidence. You have to know something. You have to know what you're doing a little bit. You can't just put these people in the box and go, here, go kill somebody. You know, it's scary sometimes.
It is scary sometimes. So, let's hear how this ended. I'm almost scared.
So this patient did not have a cardiac event. There was absolutely nothing wrong with this man's heart, but his potassium was 8.6.
Oh,
that'll do it.
So they put him on
dialysis.
They quite literally watch his EKG go back to normal.
Right.
through the process of dialysis. He gets admitted. Dialysis is not permanent for this man. It was simply a acute kidney injury that required dialysis. That did not turn into a chronic kidney injury, or chronic kidney disease, I should say.
Was it? I'm just wondering, was it something he drank, or so, like went too long without drinking something, or like what the fuck did he do? Took the wrong medicine? I don't know.
So he stopped taking care of himself when his wife went away for him.
There it is.
That always happens.
There it is.
Craziness.
Yeah, man.
But I'll tell you, I alluded to it earlier that there's more than just like one cause for this, right? Like,
yes.
And it's one of those things, like, I hate cardiology for that reason, is that it could be heart related. It could be, electricity related. It could be, enzyme and electrolyte related. It could be medication that they took related. It could be trauma related. It could be so many different things. And yeah, sometimes you go in and you don't know. But there's a lot of evidence in there. You were even saying, the T waves were humongous, right? A lot of them were flipped, like there's that.
A wide QRS, like everybody learns that, hyperkalemia shows as a peak T wave, but what's the next step after that is that wide QRS.
Is that wide QRS, exactly.
Yep.
So yeah, I mean, it makes perfect sense. I just almost wish that they took the time to ask a few more questions.
Yeah.
Because
so I think this would have been easier for them to figure out had they done more of an in-depth assessment. Just like, hey, what's your history? Oh, okay, well, the blood sugar's 90 now, so that's fine. Like,
right.
Do you know a diabetic that has a blood sugar of 90? Because that's kind of a red flag for me.
Yep.
Like, that's interesting in and of itself.
So like a dialysis patient, then we literally could have dumped fluid into him because the fluid wasn't where it was going to cause an issue.
Right.
So the hospital actually did bolus him with like 2 liters because he is fluid overloaded, but it's not where it's
supposed to be, right?
And they were attempting to bring his pressure up, which worked to a certain extent, but also you have a little more leeway with that in a hospital because you're doing dialysis in 10 minutes.
Right.
So,
right.
Well, it's funny, because I mean, ever since we had that one call review we did and stuff, like anytime I get somebody that I have a hint that there could be something along those lines, like I'll actually stop and think about it and be like, okay, you know what? I probably could give them some fluid because I don't have to worry about it. They're not going to drown,
Right.
So yeah, that would have been probably a good thing to do.
Yeah.
So,
I was going to suggest even maybe giving this guy an albuterol treatment because albuterol helps that transport across the cells with that, potassium, get that back across there. You know what I mean?
We don't have we don't have the labs though, but
right.
Yeah.
And that's
Doesn't matter. I mean, you're suggesting, with the wide QRS, and the swelling and stuff, you need to get that fluid back across the cells. Your third spacing, it helps with that,
Right. And, there's evidence out there that, that bicarb will do things for potassium. There's
we do have a hyperkalemia protocol.
Right. There's a lot of, mixed evidence on what bicarb will actually do for helping potassium. But in this case, they've already had the EKG changes and some detrimental ones. If they're actually thinking hyper K, why aren't we giving the calcium to protect that heart?
Yeah,
And
we don't have access.
oh, that's right. They didn't have access because they didn't want it. That's right. I forgot.
We were scared to drill on a walkie-talkie.
Yeah, God forbid.
We didn't hear you, Butch.
We were scared to drill on a walkie-talkie.
Yeah. God forbid that we treat our very sick, very unstable patient.
I was just waiting for him to say something about bicarb.
I'm fighting my tongue. But in all fairness, for hyperkalemia, you give bicarb.
Yeah.
That is one of the appropriate treatments for it. So I'm all about it. But
there you go.
The only thing we don't have for hyperkalemia that would really also help work is insulin. That's a major transport across the cells. I mean,
right.
But if you only give one drug to a patient you think is hyperkalemic, give them calcium. Protect the heart.
Yeah.
Yeah.
Yeah, and that's it. So like, you know, this was funny. I wish Kelsey was here for this because her and I had a very interesting conversation when she was in medic school, because
I'm sorry, I just got a wonderful shot of Butch's foot in his core power milk. Fantastic.
I see it.
How about that? Is that better?
Oh, that's beautiful. What a lovely carpet you have.
It's a nice floor.
The floor will be good for you.
That floor will be good for us.
But yeah, no, it was Kelsey and I had the conversation one day during ride time, because she was like, no, we give calcium in hyper K because, you know, it pushes, you know, potassium into cells. And I'm like, no, it doesn't. I'm like, it does nothing like that. All it does is create a buffer around the channels of the heart so that potassium doesn't get inside of it. And she
stabilizes the cardiac membrane.
Right. And she's like, no. And I'm like, look it up, woman. And she finally does. And she's like, oh, okay. Well, they taught us that wrong. And I'm like, whatever. I'm like, but apparently that's not a known thing. Like,
it's not
to some people, you know? So yeah, I think it's good that you brought it up, and that, you know, if anything, the two biggest ones are insulin and calcium. The fact that most EMS agencies don't carry insulin, go with the calcium. It's that simple. You know, the last hyper K patient I had, it was albuterol and calcium. Yeah. Till the cows came home. Yep. You know, because
I mean, the albuterol is not going to make a change in the potassium to the point you need it, but that's the only tool that we have in an ambulance to try and move that potassium. So like, why wouldn't you give it?
Right. And I specifically asked the doc for bicarb, and they said no in that case. Because I was going to do bicarb calcium and the albuterol, and they were like, no, do insulin, calcium, and the albuterol. And I was like, well, doc, it's like, I don't carry insulin. You know, if you actually took your test like you're supposed to, you'd know that. But I got bicarb calcium and albuterol, and they're like, no, we don't want bicarb. So just do the calcium and albuterol. I'm like, okay, whatever. Like, whatever. Sure. You know, but yeah, hey, no, it's.
She's like fucking Beetlejuice. You say her name 3 times, she pops up active on fucking Discord.
Ah! she heard her ears ringing. Yep, heard her ears ringing. Mm-hmm. But yeah, no, I think that was great, Em. You did great. Write some more. You'll be presenting all the time.
My one.
That was excellent.
One for the year. That's garbage.
Well, hey, we're getting closer because it was one for the year instead of one for 2 years.
That's true.
I did one last year. It was so bad we deleted it.
That's what I was saying. It didn't actually get put up. But.
That's only because we had horribly equipment at the time, and we couldn't hear ourselves. It sounded like I was talking about 16 feet away from the.
I thought it was, and it was. The sad thing was, it was like one of the best ones we ever did.
I know, and Emily talks so much, which never happens anymore. It's so sad.
I know. It was freaking awesome.
People miss.
Okay,
your
I'll
voice,
talk more.
They want to hear if you agree or disagree with Gerard. Not only when you just have something to say.
Just disagree. You're probably in a safe bet.
That's not true.
Nah.
That's why I don't talk. I agree with the majority of the stuff you say.
That's probably a bad thing.
It's probably not a good thing. Yeah.
So, anything else to add to this one, guys, before we say toodles for this month?
I don't know. I'm kind of good with this.
I think I think
don't be afraid to treat, and if you ain't got confidence in yourself, ask yourself why and fix it.
Yeah, and I think that's the big takeaway from this is not only just knowing the EKG changes for different disease processes and stuff like that, but also there was a fear and a lack of performing the care that you're supposed to. And it was almost like, what's that saying when you're like, nothing happens because you're locked into fear. Like you just have that fear overload and you're stuck, you know?
If I may quote the great Gary Busey,
Okay.
fear causes hesitation, and hesitation will cause your greatest fears to come true.
There you go. Look at that.
Ooh, look at that.
Ooh, look at that. Yeah, and I think that's something to take home in this.
Only one person knows where that came from.
Yep.
You're also like 20 years older than everybody, so
Fuck you.
you're welcome.
Wow. Damn.
Oh, did that come out loud? I'm sorry. It was under my breath.
Yeah. So, yeah, I think that's where, you know, the big focal point needs to happen is if you're a provider out there that has been in a similar situation where something like this happens, where you're kind of frozen and you don't know what to do, and you're you know, you're not running down your protocol, but you're delegating and you're, you know, relegating your decisions to people who are smarter than you because you don't know what's going on. I think you need to sit down and have a hard look at how you practice, because that's not a good way to practice. Not saying that the doc can't save you, but it shouldn't be their responsibility to save you.
You
Well,
also
let's
have to remember that if you're going to come off as this incompetent, scared paramedic, the chances of them giving you anything is slim to none. They're going to be like, no, just get him here.
Right.
Right. Yeah, don't touch anything.
Right.
Yeah, exactly. Drive
And I
faster.
was gonna say, even if you're not the smartest fucking bulb in the batch, I mean, like, it's pretty safe to say that I'm in that batch, and you don't understand all the freaking pathophysiology and A&P and all that shit and all that wonderful science, but you know you don't know that. So recognize that
Mhm.
and be good at even just basic shit and doing your skills. These guys, like, they didn't have to know about cellular freaking diffusion or any of that shit. All they had to do was know how to interpret that EKG right, and then know how to do it and know how to fix it.
Yep.
You know, or even if they didn't understand that they were looking at hyper K, even if you didn't understand that, you knew that, hey, you know what, his heart rate is too slow and his BP is too low. I should pace.
Right.
Okay, how do I pace? I give a little bit of freaking pain management, and then I just fucking get the capture and start hitting them.
Right.
Done. You know?
Yeah, and I think
You don't even have to be smart to look like a fucking genius.
right.
You know?
And that's it. You know, we have limited knowledge of all of this stuff as EMS providers. They only give us a little bit of the pie, you know?
Right.
So we're not expected to know cardiology level stuff, but we know enough to be dangerous.
What was that?
I'm so offended.
Well, I was just going to say, you just said that in the presence of greatness. You dare speak like that?
Okay, one out of the many, again, slim slice of the pie. But yeah, I think it does a disservice to everybody, you know, because again, what is the doc going to do? They're going to tell the next doc and the next doc and the next doc.
Right.
And then sooner or later, no docs are going to trust what we do.
Right.
You know, they already don't. And now we're just giving them more and more reason not to, you know? So yeah, I think it's a hard lesson to swallow,
Yeah.
you know?
Yeah, I mean, just, it really goes back to just, know who you are. I mean, if you know you don't know a lot of shit, well, then figure out how to freaking make it look good, you know? Plain and simple.
Yeah, just learn it.
Yeah.
Yeah.
I mean,
That's-
again, it would not have taken a fucking rocket scientist to walk this freaking patient in better shape than they did.
Right.
Boom. You know how to use the drill?
Put it
Yeah,
on the
good.
heart.
So you would have access. You know how to freaking put some fluid in? Yep, you can put some fluid in. You know how to pace? You know how to pace. There you go, done.
Right.
Yeah, not a fun experience to have to drill somebody that's looking at you and talking to you. It's not fun. But
Right.
sometimes you got to do it.
Sometimes you have to do it.
In Gerard's
know,
case, a lot of
Maybe
times
that'll
gotta
give
do
you
it.
a little more ambition to do better on your IV skills.
Yeah.
Ooh,
Yeah.
burn.
Burn.
No, I mean, seriously.
But it's true. though,
As our
like-
camera just fucking perfect timing just tips over and falls. It's like, no, seriously.
Balancing
done.
on a charger.
I'm done. All right, guys. Well, thank you, Emily, again for presenting. I enjoyed it. You should probably do more. Gerard's giving you the slow clap.
No, that was a normal. That wasn't a golf clap. That was a golf clap.
See, I only saw
Legit
half.
clap.
I only saw half of it. Like I saw just your finger.
Oh yeah, no, I was monkey with the cymbals clap.
Oh yay! All right. Well, she gets a macho man. And Gerard, what do you got for us?
I got don't be an idiot, freaking donuts.
Thank you for listening to today's episode. If you'd like more information on the podcast or to send us a call to review, visit medicmaterials.com/podcast. To learn more information, like us on Facebook at Medic Materials EDU, or watch our weekly instructional videos on the Medic Materials YouTube channel.